Hi everyone, welcome to the 4D show. I am Dr. Prashant Arun, consultant physician and diabetologist at MV Hospital for Diabetes. So today we're going to be seeing about the challenges and solutions in the treatment care for diabetes. So when we say challenges in diabetes, it is number one, it is very difficult to make a patient understand that is in the beginning stages that he has diabetes, because most of them, when we tell them that they have diabetes and they have to start taking medicines, they say, first, can I just try losing some weight? Can I try doing this? Can I try doing that? Can I try this diet? They don't just want to start taking tablets. Maybe they would have done it when they're pre-diabetes, yes, but not once they have become a person with diabetes. Definitely we cannot tell them, okay, fine, then you cannot be on medicines, because they don't generally want to start medicines because they have been hearing so many things about medicines. And if you take your medicine, you're getting this problem, that problem, so they just generally don't want. Number two, even after a patient is started on medicines, maybe if his blood sugar is not coming under control, or maybe he develops some kind of hypoglycemia. And definitely if patients develop hypoglycemia, the fear becomes so much they just stop medicines. And after all this, if their blood sugar is not under control, and then if you have to put them on insulin, that's the most, again, people are just scared. They don't want to be on insulin. And we say insulin, people just say, no, sir, I don't want, give me one more month's time. So these are all the, technical challenges we could face maybe while handling a person with diabetes. And maybe for the solutions also, we've got with us Dr. Saj Ahan. He is a consultant diabetologist, endocrinologist, and he's finished his MD General Medicine. He's finished his MRCP, Endocrine and Diabetes. He's an academic member of the American Association of the Clinical Endocrinology and the American Diabetes Association. And the past associations, he is a senior registrar in the Department of Endocrinology at Indira Gandhi Institute of Medical Science, Patna. He was an assistant professor in the Department of Internal Medicine at KMCH, Bihar. And he is a scientific speaker and faculty at various international, national, and state conferences like the ACE, RSSDI, Indian Podiatry Association. He's even in the research and scientific publications he's done in the Indian journals and publications also. So on to you, Dr. Sajid Asan.
Thank you, Dr. Prashant. Really, it's a generous introduction from your side. And really, I would like to thank the entire your team for inviting me on this 4D platform. So you have touched all the aspects, the basic problems and the challenges, or what as an Indian population. Basically, I will in my entire talk I will focus about this Indian population, Indian subcontinent. So we are a different kind of the population as compared to the Western counterpart, both genetically as well as this phenotypically. Also our environmental factors are different. Causes of diabetes are a little bit different from the Western side. We have different kinds of the problem in terms of cardiovascular disease, which is considered as a biggest challenges and nowadays with the diabetes. Apart from so many microvascular complications we deal in the diabetic patients like nephropathy, neuropathy, but now what we are witnessing over the last 1 decade with the diabetic population, especially the type 2 diabetes population, we are facing more cardiovascular challenges, and specifically this heart failure burden is up to a big rise. It's taking a big toll of our entire population. If you see our own registries, Trivandrum heart registries, if we will talk about, we have a good incidence of the heart failure, almost 54%. And the worst part is this, that our younger population is getting diabetes and heart failure an earlier time. So these are some challenges. And when you talk about the uh, treatment aspects, as very well said by you, that we have most of our patients, they delay the treatment. They do not want to take treatment at the right time, right moment, as prescribed by the most entire our clinicians fraternity. But always they want to do it. We will just go by this lifestyle management, also dietary modifications. So these are the really challenges. I will try to just discuss about all these aspects.
So we can
So,
have the slides, right?
okay, please go ahead, because so we have diabetes is a big issue. And if you see the IDF data, International Diabetic Federation data, we are just next to the China in terms of number of people living with the diabetes in India. And really, it's a big concern. Until 2045, this number is going to see a big surge. Almost 45 million people in the India, all across the India, we will face with the diabetes, and it will take a national big huge burden with respect to not only the number of people with the diabetes, but a big economic constraint also we are going to have it as a nation. So what are the challenges and what could be the possible options and the sort of the way we can go by which we can improve this pathetic situation we will talk about. So please go for the next slide. So if you talk about the basic challenges, first of all, we will see the unless and until we will impart education and the proper counseling to the entire population across the India regarding the risk factors of the diabetes. If you see the recent changes and the transition in the diabetes, so what we see that there is a term generated right now these days, diabesity. Obesity is one of the biggest risk factor. That is why they have coined this term with this diabesity. Diabetes and obesity are so interlinked that obesity is considered one of the biggest challenges. And nowadays most of the modern anti-diabetic agents, like when we talk about GLP-1 agonist and SGLT2, they covers this aspect of obesity also. Apart from that, a bad lifestyle, less walking, more eating, these are the very common things here. If you see in the very common words, these are the biggest challenges with our population. The kind of the affluenza of the, with terms of the bombardment of the food we are having, we are creating more oxidative stress in our body, giving much stress to our beta cells which produce insulin with the bad kind of the food. So this is the one of the important risk factors which we need to impart to the entire population, that eat less, eat healthy, and eat on time. So if you follow these basic three rules, definitely you will just cut down or delay the onset of diabetes in your population. So, but whenever we came across to any person with the diabetes, whether it's a type 2, so it's always good time to start to discuss about all the treatment possibility and the options we have in our armamentarium, whether it's an oral anti-diabetic agent or the insulin, depending on their need. We need to discuss with them that this is the right time. Either you should start with the OADs, or sometimes if they have some insulin deficiency, so you need to explain them, you need to talk to them. Because what I do in my practice, that I just give the example of just you have to hit the diabetes with this punch, and if you want to make this punch, you need 5 fingers: first, second, third, and fourth, and fifth, and you have to take it simultaneously to make this punch. And the first finger is your dietary management, your walking. At least you have to do 150 minutes of walking, your lifestyle, your exercises, and your drug or insulin, whatever is needed, and the stress management. So these are the 5 fingers of the management of diabetes by which you can make a strong fist and hit the diabetes right time. So but still, if you go do a proper counseling, you can counsel your patient. At least you can develop their confidence to start their anti-diabetic therapy. So this is the training and the counseling of the patient. This is very important. And but what we have, we do not have this very proper infrastructure also, either even in the bigger cities. So we need to develop a structured care activities. So we just do not we should not do a bombardment of the all kinds of therapy at that time. At the same time, your clinic should be at least equipped with a good dietitian, a good counselor also. So these are the part of the some structured care activity. And apart from that, in a not in a fearful way, we need to counsel them, we need to educate them about the cardiometabolic risk factors also, which are the common risk factors both for the chronic kidney disease also, the cardiovascular diseases, and the diabetes. So if you see the entire risk factor, if I will talk about one very famous study, that was the Interheart study published, that paper was published in the Lancet in 2004 by Salim Yusuf. That was a study which has conducted in 52 countries all across the globe, and they have assessed about the 9 modifiable risk factors of this cardiovascular diseases. And in amongst that, if you see, the most important factors were the hypertension, diabetes, and the lipid profile, which we can easily modify. So apart from that, we need to diagnose early, at least to detect this subclinical diabetes, or we can say pre-diabetes early, and make aggressive and early control of the glycemia. Because all of us know that we have some very good landmark trials like the UKPDS trial. And if you see the another trials of like Accord, Advance, and the VADT trials, so what was the difference between these three trials and the UKPDS trial? All these trials gave us a good, very good lesson that if you treat diabetes intensively and aggressively, you will reduce, and you will reduce the microvascular complications. All these trials have proved. But if you treat diabetes very aggressively from the beginning, then only you can bring down the changes in terms of the cardiovascular outcome. And that was the peculiarity of the UKPDS trial. They have included all the new diabetic patients, and they kept a very good control from the very beginning. So this was the lesson, but the same results we didn't find in the Accord, Advance, and the VADT trials, in which they have recruited already the patients of 10 years or 9 years or 8 years diabetic patients, and previously they were having a bad control. But after 8 years, if you will give them intensive control, of course they will come up with a good microvascular outcomes, but not in terms of cardiovascular diseases outcome. So early and aggressive control is quite mandatory to bring out some good outcomes in terms of the cardiovascular outcomes also. But apart from that, we cannot say at this point of time that we need to treat or we can treat each and every patient just with one shot. We have to design different treatment protocols for different subset of the patients, individualize their glycemic targets also. Because if a person, frail person, elderly person who is above 75 years of age, and he is dependent on the other caregivers, and he is having so much and so comorbidities like CKD, heart failure, so you cannot say that in that population you need to keep an HbA1c below 7, because hypoglycemia is another risk factors for those subset of population. So that is why if you see the ADA guidelines also, they have leniently bring down these criteria for those dependent patients to keep their HbA1c between 7.5 to 8.5. So that is a one individualization of the treatment targets. Considering the comorbid conditions is quite important, because if you see the most of the recent guidelines, whether it's the ADA 2020 guideline, American Association of Clinical Endocrinologists, they have also telling the same kind of the things. They tell us there is a shift from a glucocentric approach in the diabetes management to consider the cardiovascular and the renocentric approach. If your patient is having heart failure with reduced ejection fraction, of course, after metformin, SGLT2 classes of the drugs are a good options, and guidelines are advocating them. If your patient is having ASCVD, cardiovascular diseases risk factors, strong risk factors, GLP-1 agonists can take a upper position in your diabetes management after lifestyle, metformin, and then GLP. And if your patient is having CKD and proteinuria, of course, SGLT2 inhibitors, those who are having a clear-cut evidences of reducing the progression of CKD. And if you see all the good trials of SGLT2, whether the renal dedicated trial, the Credence, now we have two very good trials came up with the DEPA CKD and the IMPA CKD. These all trials has proving that SGLT2 class of very good molecules in diabetic population as well as in the non-diabetic population to reduce the progression of the CKD and the proteinuria also. So individualization of the treatment is now the major focus. If any of your patient is having frequent hypoglycemic symptoms with the sulfonylureas or the insulin, so now we guidelines are also advocating to consider those drugs which have neutral potential for hypoglycemia, like the DDP4 inhibitors, glitazones, SGLT2, GLP. So there is a good choice in the basket. If your patient is very obese, much having very high BMI, with so much and other risk factors like obstructive sleep apnea, and in that category, GLP-1 agonist and the SGLT2 class of inhibitors are a very good choice because they promote weight loss. But one point I need to mention at this is quite important. In spite of having so many good molecules with such good properties, just be strict with one thing. If your patient is having presenting you with a very high blood sugar, uh, with some symptoms of osmotic symptoms, with a catabolic state, then you need to definitely, that is a good candidate for the insulin, and we should never forget it, because these patients are always prone for sometimes ketoacidosis. And insulinopenic patient you can easily identify by their symptoms, their high A1C, their high blood sugar, their catabolic symptoms, and their osmotic symptoms. And at that time you need to start with the insulin, sometimes also either with the basal insulin or the premix insulin. But of course, most of the guideline writing society, they prefer the basal insulin to start with if your A1C is more than 9 right now. So please, next slide. So, what are the barriers and what are the possible solution? So, of course, if you want to sort out some kind of the problem, you need to know the problem statement. If you want to give your patients a optimal standard of the diabetes care, bring down, if you want to have a good metabolic control and diabetes self-management. Apart from giving good education about the disease process and the disease condition, you need to consider their economic cost factors also, because you cannot give your each and every patient, in spite of having some good properties of this GLP-1 agonists, because these are very costly. You should delay the risk. You should cut down their other stress level. The stress, whenever I talk about the stress is just not in terms of the psychological stress. Of course, that also brings up your adrenaline and upsets your cortisol. But so many other conditions like inflammatory conditions, you need to identify your patients like their inflammatory arthritis so much, and so behavioral changes, their food habits. You need to consider that why this patient is having the risk factors from progression from pre-diabetes to diabetes. So these you need to know and identify these factors. And if you, for this, one very important clue is, and tip is that a careful medical history is, I think this is the best possible solution for identifying your patients. You need to talk to them. You need to talk to them, their caregivers and relatives, somehow their wives, and somehow in case of wife, you can talk to their husband. Poverty, economic, different kind of the economic strata we deal with in our practice, different kind of the multilingual population. So the entire information, if you want to give them in a very simple language, in their own language. Religious and the cultural beliefs are sometimes obstacle in some kind of the management. So we need to consider all these when we go for a comprehensive management of identifying the problem statement in our diabetic patients or pre-diabetic patients, or those patients who are having strong risk factors for this diabetes. Next slide. Next slide. Please move to the next slide. Okay. So the strategies to manage the pre-diabetes. I think pre-diabetes is the just the right point where you can intervene and you can make your patient sometimes not in, you can say, the reversal, but you can make them into the remission point of the diabetes. And for remission, the first step is the definitely the lifestyle management and all the guidelines. If you talk about, they at least suggest to have a walk of 150 minutes in the entire week. Regarding the calorie burden, we right now we are having the kind of the fooding habits been developed in this our society. Almost some of the studies I have gone through that this Indian population is right now consuming between 2600 to 3000 kilocalories per day. So it's we are overburdened with the calories. That is creating more oxidative stress in our body, more giving more oxidative stress to our mitochondria. So the guidelines, they suggest if you want to cut short the diabetes in your pre-diabetic patients, you need to reduce the calories definitely. And all the hypocaloric diets trials which they have conducted between 800 to 1200 kilocalories. So if you see the look ahead trial also, which has conducted a very big trial on with the lifestyle and the dietary management, they have taken a very low calorie diet plan and intensive lifestyle modification program. So in the look ahead trial, they have achieved in those subset of patients up to 10 to 15% of the reduction of the body weight those patients were gone into the remission of the pre-diabetic state or the diabetic state. So a good weight reduction up to 10 to 15% of the body weight loss can make you free from most of the metabolic disorders, so which I talk about mostly in the females. PCOS is a condition in which you need a good weight control, and that is also a pre-diabetic condition, a risk factors over the future diabetes. And apart from that, we have some drugs also, not only in the diabetic armamentarium, rather than we have in the obesity management previously, we have this lipase inhibiting drug, orlistat. Some data are suggesting that this, by just reducing the fat absorption from your gut, you can bring down the risk factors from the conversion of the pre-diabetes to diabetes. But some of the very good drugs, like we have GLP-1 agonist, we have now oral drugs in GLP, semaglutide also, although they were not approved in the pre-diabetic conditions, but in diabetes, if you use these as early, you have a very good weight loss, and that makes sometimes remission. And some of the good studies with the early usage of the insulin with the onset of the diabetes, the early usage of the insulin in your diabetic patients, that may lead to sometimes in the not in remission, but sometimes remission state of the diabetes also. That is the one paper by the Rains stall, although those studies were very small, because if we give insulin early in the diabetic patient, either with the support of basal insulin, so this gives at least rest to your beta cells, help them to rejuvenate, or you can say scientifically we tell this, we use this term de-differentiation of the beta cells. This reversal process is somehow remission process is very sometimes we achieve. Some of the studies are suggestive that we can achieve this remission with the early usage of the insulin also. There are some good drugs in our diabetic set of management in our arsenal. That was the gliptins and the pioglitazone. These are the two classes of the drug in which they have proved with the animal studies that these drugs are quite protective or friendly to your beta cells. And by using these classes of the drugs early in the diabetes management, we can have a very sustainable and a durable control of the diabetes with these classes of the drug. And if you deal with somehow a morbid obesity patients above 40 BMI and the 45 BMI with so many other comorbid conditions, there are very good data with the bariatric surgery, that if you these patients have undergone with the bariatric surgery, there is a reversal of the diabetes or the pre-diabetes with a good amount of the weight loss in those subset of patients. So these are the some ideas, some preliminary studies which gives a direction to move with this kind of the things. And although we need to individualize this, whatever I have talked that about these individual options, we need to individualize these kinds of the therapy considering the patient profile also. So we cannot apply the same thing on each and every patients. That suppose if I've talked about the insulin therapy, of course you cannot give it to each and every of your patients. But if your patient, some of your patient is having HbA1c of 8 and 8.5 and is started with the catabolic symptoms or the osmotic symptoms, and if you start insulin early in them along with some OADs, like and one point I need to clear at this point of time, that early and aggressive use of the medical therapy, now this is also been advocated by the most of the standard guidelines. Like if you see the AS guideline criteria, so what they say, if your HbA1c is below 7.5, you can go with the one drug. But if your A1c is between 7.5 to 9, you can either use a two drug or a triple drug combination also. So previously and traditionally, what we have been taught in our medical schools, we have to go with the lifestyle and modification for 3 months, 6 months, then start metformin. And that time, if you see, that is a too late, and most of our patients develop some kind of the complications, and that is a huge burden and the toll on the beta cells. And there is a deterioration theory of the beta cells. Differenzo's data, we have know that at the time of onset of the diagnosis or at the time of pre-diabetes also, there is a 50% beta cells loss. And if you have a frank diabetes, almost 70% of your beta cells you have already lost. So please move to the next slide. Therapeutic strategies, I think most of the things I have discussed about this novel medication therapy, apart from metformin, good old, we have good data with the metformin. DDP4 inhibitors, they are a wonderful class of molecule. I'm very fond of this, all these DDP4 inhibitor. But amongst the DDP4 inhibitors, you need to take care with the individual agents also, because if you see the entire CVOT data of all these DDP4, we have some concerns with the some molecules also, like still now. But if you see these two molecules, sitagliptin and the linagliptin, they have very good and proven data with respect to the good trials. The course trial was done with the sitagliptin, and they have proved that this molecule is CVOT neutrals in terms of cardiovascular outcome. They are quite safe in your cardiovascular patients and the heart failure patients also. Linagliptin, they have very good trials, two good trials, Carmelina trial and the Carolina trial, in which they have compared with the glimepiride. And linagliptin was that molecule which has shown, as a comparison with this glimepiride, that this gliptins are a good class of molecule which can give you a sustainable and the durable control as compared with the sulfonylurea, but at a very less weight gain and less hypoglycemia. So these are the two biggest advantages with this molecule, DDP4 inhibitors. Severtimi trial was done with the sexagliptin, in which they have found that there was a 27% increase in incidence signals of the heart failure with this molecule. So be careful with the usage of this molecule, sexagliptin, in your heart failure patient. SGLT2 inhibitors, there is an amazing class of molecules. They have been launched in 2014 when, as an anti-diabetic agent, and some everyone were surprised at how these classes of molecule, which by just excreting the sugar through your kidneys and the urine, so how can they make an impact on the blood sugar? But they have proven a very good glycemic efficacy of up to A1C reduction of 0.28 to 0.8 to 1. But apart from that, some amazing data in terms of the heart failure, whether it's a IMPAREG outcome trial with the empagliflozin, CANVAS trial, and then declared TIMI trial with the dapagliflozin. All these trials have shown some secondary good outcome data with in terms of prevention of the heart failure with all these molecules. Empagliflozin was a one very good molecule which has shown to reduce the CV death, 38% reduction of the CV death. But later on, we have some very good heart failure treatment trials, and DEPA-HF was the first landmark trial which has shown that this SGLT2 dapagliflozin has a wonderful effect in terms of prevention and treatment of the heart failure, not only in the diabetic population but in the non-diabetic population also. So this, and after that we have imperial reduced data, imperial preserved data. GLP-1 classes of the molecule, they are wonderful molecule, although a little bit costly beyond the range of the masses. But if you see all the data from the LIRA trial with the liraglutide, now we have semaglutide, pioneer series of the trials that they have conducted. These classes of molecule are wonderful molecule in terms of A1C reduction, with and weight neutral or weight loss, weight neutral rather than say, we say all these molecules have a very good weight reduction property, and they have a very robust CVD outcome. So these are the wonderful classes of molecule, and now the diabetes management is quite easy, we can say, with all the availability of all these molecules right now. And early initiation of combination therapy, there is no harm, and guidelines are also advocating them that if you picturize it, this differentials octet in your mind, you will see this there is an 8 pathophysiological sites of the diabetes, and if you just target one site, you will miss other targets, because diabetes is not caused by single etiology. You need to hit multiple targets at the same time, and that will give you comprehensive and good control and the preservation of your beta cells. So I'm not going to the entire details of, but still, if you see, we cannot say at this point of time that metformin is an obsolete therapy. Metformin is the base of all the therapies, and all the therapies on the top of background of the metformin therapy can make a very good impact in terms of A1C reduction, also in terms of other benefits also, whether it's a cardiovascular event or the renal failure, because metformin is a very good drug which has a very good cardiovascular safety outcome data. And apart from that, it reduces the hepatic gluconeogenesis. It has a very significant impact on your fasting plasma glucose. It makes a good impact on your weight also. your entire insulin resistance can you can bring down with this usage of this molecule metformin. And one molecule at the least, last but not the least, I will discuss, which is the most neglected molecule right now these days, and that is pioglitazone. Pioglitazone, whenever you write as a diabetologist or endocrinologist, and if the prescription goes to a cardiologist, so the cardiologist always make the patient scared. Oh, doctor has written you, which will make you land up in the heart failure. That is not true, because if your patient is not having in the state of heart failure or not having a bladder carcinoma, you may carefully select a subset of the patient in which those who do not have a risk factors of the heart failure, not established heart failure, no bladder carcinoma, no osteoporosis, and pioglitazone is also a good class of the drug. And we have very two good trials, proactive trial and the iris trial with this molecule, which has shown a good cardiovascular and the stroke reduction properties in this with this molecule. But be careful, and NFLD is the only category in which if you can give this molecule in the diabetic population with the NFLD and the NASH population, by which if we have a good reduction in the progression of the NFLD and the NASH, and we have very good trials like PIVENS trial, which has shown the benefit of the pioglitazone and the vitamin E in a high dose of 800 international units of per day with this molecule. So these are the all molecules we have, but we as a clinician we need to we need to do justice with our patient, that at what kind of the patients we need to select what kind of the therapy at the right moment, that will be make a good impact on the management of your patients with the diabetes. Next slide, please. So, other actions we need to consider that, of course, this is not the other action. First action we need to about the patient education and empowerment of the patient, because unless and until we will not empower our patients regarding the disease process, regarding their therapies, suppose just the empowerment is most important aspect. When you insulinize your patients, always you need to teach and bring their confidence just by letting them know how to take insulin just by in your office. If you give your first them their first insulin dose by your own hands, that will bring them confidence too much high. And apart from that, you need to teach them when you insulinize them about the up titration of the insulin dosage, teach them about the hypoglycemia. Right now there are many apps. Be in contact with your patients either through your diabetes educators or some apps or some kind of the telemedicine strategies. So definitely this empowerment and boosting of the confidence of your patients make them a great impact if you insulinize them. Definitely. Otherwise, they will are so much fearful with the insulin therapy just by needle prick, fear of injection, fear of hypoglycemia, and the social taboos regarding the insulin. So you need to overcome their all these obstacles and the queries regarding the insulin, and always be in touch with your patients. Always make a frequent call and make a frequent appointment with those patients, especially those patients who were on the insulin therapy. So this will make a big impact and regarding their approach in the acceptance of the insulin therapy also. So next slide, we have any next slide?
No, no. I think we have come to the end of the slideshow presentation. That was a
Thank you, thank you,
detailed
thank you.
explanation, and it was wonderful hearing from Dr. Sajid Asan. So, as doctor was saying, because nowadays people are on a 2,600 to 3,000 kilocalorie diet, and we recommend them to be around a 2,000 to 1,200, 1,800 kilocalorie diet. But 100 years ago, before even insulin could be invented by Sir Banting and Best, people used to be on a diet which is as low as 400 kilocalories when they had diabetes. And they didn't even die of diabetes, they died of starvation, because people even ate, they didn't know how to control their sugars, and the sugar started shooting up. And that well nice point that sir was talking about, that even at the time of diagnosis most of them have lost 50% of the beta cell. So at the time of diagnosis, when you try saying I'll take tablets after a while, it actually becomes late. So with this, let's move on, and to start with, as sir was talking about pioglitazone and DPP4 inhibitors being his favorite, and he uses it more, we've got the latest lobiglitazone also, which is actually helps in increasing the insulin sensitivity. So can you throw some light on the latest lobiglitazone for us, Dr. Saj?
Actually, this lobiglitazone is the same kind of further extension in this. This also works on this PPR gamma agonist. This also reduces the only the manufacturers they claim this is causing less fluid retention with this molecule you will have, but we do not have enough data with this lobiglitazone regarding the heart failure population. So but of course, let the time goes on, we will accumulate more data with respect of on those risk categories population with this lobiglatazone, and then the future will be definitely. But one thing I will add this point of time, we have another molecule that is saroglitazole, which is a PPR alpha and gamma agonist, and this molecule have been widely tested in most of the trials, press 4, press 5 trials, and they have a good advocacy in the NFLD population in the hypertriglyceridemia. So, if some of your patient is really a concern about this obesity, they have less weight gain. This saroglitazole as a molecule is a good choice in the reduction of the insulin resistance and the management of this dyslipidemia. And typically, Indian diabetic dyslipidemia, if I'll tell you, we have a very good study by Dr. Professor V. Mohan and his group, which was conducted ICMR in-depth study, in which they have clearly stated that while rest of the world is much more concerned about this LDL cholesterol, but our Indian population, if you see their cholesterol population, if you're in your own clinics, they have a very high triglyceride level, less LDL. But those LDL in our population are atherogenic, small, dense, condensed LDL. That is more atherogenic. So we have a different kind of dyslipidemia. And if you see some of the good trials, Miracle and the DIAL outcome study with the high dose intensive statin therapy, what they say, even with the intensive use of statin therapy, if your triglycerides are very high, you have a residual risk of cardiovascular disease. So we cannot say that triglyceride is not a risk factor for our diabetic patients. We need to consider them also.
Yes. And can we have your opinion about this continuous glucose monitoring systems and the latest insulin pumps? Because most of the patients with diabetes, they'll have to prick several times to check their blood sugars. That is the self-monitoring of blood
Of
glucose. And if they
course,
are on a
CGM.
basal bolus, huh?
Of course, those patients who are either type 1 diabetic patients, diabetes in pregnancy, CGM is a boon for them to reduce their glycemic variability. And if have an access and the privilege of having those CGM system with your patients, definitely they will make an impact on their HbA1c reduction outcome also. We have good data that with every 10% reduction in the time in range, you have a better A1C outcome. Some of the recent papers, exactly, I don't remember the name of the author. It was Beck et al. So CGM is in a very simplified term, it takes care of whole day 24 hours glycemic excursion, either interday or intraday. So just having making a patch on your skin, and you clearly monitor your patients, and you can modify their insulin dosage on the basis of their CGM data. You can modify their diet plan at what time they are taking much carb. That is why you are having most postprandial surge. So this is a really helpful tool, but not widely and accessible to all the. I think it's
Yes.
not a ground level reality, but of
Yes.
course at certain points of time, you if you have access, definitely you should go for it.
Yes, and insulin pumps, because most of the patients with diabetes are on basal bolus therapy or on premixed insulins. They do not want to prick themselves because most of them have this fear of insulin. So, for them,
Okay.
how would you suggest this insulin pumps, and how can we calibrate the insulin pump and the CGMS together? Because then the basal is always going to be there.
So, Dr. Prashant, one thing I would like to ask you: where you are practicing right now? You are in Chennai.
Yes, yes,
Yes, yes, yes. Okay, these are the just two states, Chennai and the Kerala. I think Dr. Keshav Dev, I think he is the finest
yes.
man in
That
the India
Jyoti
who's
Keshav.
doing with
Keshav.
Jyoti Keshav Dev and the Dr. Professor V. Mohan. But here at the part we are working in the Bihar, we are lacking those facilities. We are much convinced. We convinced our patients that you are in basal bolus therapy. Your child is 6 and 7 years of age. Really, it's a troublesome and making a bad psychological impact. with multiple pricks throughout the day, you can go for a insulin pump therapy. But technically, practically, and honestly, I'm saying I am not using much of this insulin therapy pumps in my own practice, even in the type 1 diabetic patients. So really, I can't say. But of course,
Sure.
it's a hopefully a futuristic hope for
Then
all, and it
let's
should be available.
Yes. So then, how do people, because actually people in the peripheries are finding it very difficult for them to convince the patient to start on insulin, because when we say insulin, they run away. So could you tell us how to convince a patient to be on insulin, and how long could we tell them to be on insulin, or how to make a person okay for insulin?
So first of all, we need to. I what I do in my clinics, I talk to them about the first. I entirely give them entire picture of this type 2 diabetes progression. I explain them this the beta cell theory. I just give the example of from their own relatives that look at your uncle. He is having diabetes of 10 years of duration and is taking 5 and 6 drug, but still he is not in good control. He is now having CKD. So the problem is this, that this diabetes is just not by your lifestyle, poor bad lifestyle. This is something with your insulin delivery, insulin production. So if we initiate insulin early, most of the time in younger patients, I initiate insulin early, at least for 3 to 6 months or 3 months, depending on their need. If they, so what I convince them, this is the your beta cells health. We can go with the oral anti-diabetic agents, but after some times you will come back to me and tell me that, doctor, I have a bad kind of the diabetes, whatever the drug you have prescribed. So if you will take just this simple insulin, previously I show them both kinds of the needle and the pen system. This is just painless. Anna, what I need to do as a initiation program, that I just give them insulin by my own hands in my own clinic. Anna, I just tell them to just take it with me. If you have any fear, and ask them, always I ask them that whether it was painful. The patient, most of the patients, they say no. Previously, what I was thought and what I was fearful, that is so painful injection. No, this is nothing like that. So with time, these patients develop the confidence, and those patients whom I initiate insulin, always keep them in my touch. Every alternate day or third day, I connect with them and ask them what is your blood sugar. Just up titrate +2 or +4 units of insulin, depending on that. So titration is a very important part. So even if you will initiate, let me tell you very confidently, if you are able to initiate insulin in your patients, they are much more confident and they are much more happier than those patients who are on the oral anti-diabetic agents. Insulin is really makes them life very easy and better. Much they remove their symptoms of much of the not osmotic symptoms, fatigues, cramps in their legs. So there was I think a metabolic outcome was much better with the insulin, thus not bringing on the numbers with the blood sugar.
Sure. So we know that most of the patients with diabetes have anemia, and most of them are iron deficiency anemia. So can we have your opinion on patients with diabetes and anemia?
Specifically, if you divide this diabetic population specifically in type 1 diabetic, of course, with every type 1 diabetic patients, you need to exclude some of the other diseases also, like autoimmune disease, like hypothyroidism, specifically celiac disease. Every type 1 diabetic child with stunted growth, I exclude the celiac disease. And most of them, I find celiac disease. Even the day before study, I got encounter with the 12 years old girl who just looked like 6, and she was having celiac disease. So other diseases you need to rule out. But in type 2 diabetic population, of course, some of our patients they came up with the anemia. And if you see, those patients are a get bigger risk for the CKD also. If they have a normocytic normochromic anemia, CKD is a good possibility. So whatever the drug you are prescribing, always take the calculation of the GFR. Always ask about their bowel habits, because if you find any person above 50 years of age and they is having iron deficiency anemia, you need to rule out all the possible gut diseases specifically. So causes of anemia, their dietary habits are very important, especially in the females. These females, most of the time, I found they encounter them with the iron deficiency anemia just because of their bad habits. Poor a good menstrual history will give you about a good clue about this with the females. And one very specifically, if with those patients who are on the high doses of metformin, suppose 1500 to 2000, and they are on the prolonged duration of 2, 3 years and 4 years with metformin, you need to exclude this B12 deficiency also to rule out this anemia. One thing. So there are various causes of anemia and diabetic. So I think most of these were present in different subcategories of patients.
Sure, sure, sure. So thank you so much. Thank you so much, Dr. Saj Hassan. It was wonderful talking to you, and you've detailedly explained to us about all the solutions and problems we could be facing due to diabetes and all the solutions. Thank you. Thank you so much. And thank you
Thank you,
everyone
Dr.
for watching
Prashant.
this session.
Really, it was a good interaction with you too. See you. Hope to see you in the future also. Thank you. Thank you so much.
Thank you.